Hi everyone, this is Shoshana Zatz from CIB. Last Fiscal TA webinar of this fiscal year. We're not sure if we will continue these into the next fiscal year, but I hope so, very much hope so. Just as usual, you're muted, and if you have questions, please type them in the question box. Mike will be pausing on a regular basis to ask for questions. This is recorded, so within a week, we'll have a recording up on our website along with materials. I did send out the materials to everyone who was registered this morning, but if you didn't get them, send me an email and I'll as soon as I can. I think that's it. So let's have Mike.
Great, thank you, Shoshana. Good afternoon. So what we're going to cover here this afternoon is what was discussed at the last Financial Services Committee meeting, which was held 3 weeks ago and it's the typical subjects that were covered in the meeting, and we'll cover these during the call. So diving right in, ICD-10 and DSM-5 update. Basically, there really was no update other than a couple of information notices. Nobody had questions during the meeting, and so hopefully we'll start to see these notices out fairly soon. And then really we started then diving into the fiscal stuff, talking about substance use disorder update, first talking about the cost reports. So there is this new web-based cost report from DHCS for substance use disorder services for year 14. DHCS did hold 3 webinars last month on how to fill out the DHCS indicated that they anticipate August 31st, 2016 is going to be the due date for the 14-15 report. And apparently they sent out an email on May 2nd, and I'm not sure who it went to, if it went to the directors and or fiscal folks, that provided frequently asked questions, had a link to the training webinars as well as the training document. So hopefully you folks have seen those, at least those of you involved with the cost report. And they were willing to take questions on the 15-16 cost report, and nobody had any questions during the meeting. And so what they had previously said is that they anticipated January 2017 due date for that cost report, and that they may have training sometime this summer for the 15-16 cost report. And then we talked a little bit about the SAPD block grant. This first issue in terms of the overpayments to counties has been going on for quite a while. There were 52 counties that were overpaid, and DHCS is requesting those counties to refund the overpayment, and then basically they'll just turn right around and once they're ready to release the 15-16 funds, you'll get that money back. However, they're not willing to release the 15-16 payments until all 52 counties have returned the overpayments. The state then indicated that there are 4 counties that had not paid, although it was interesting because one of the counties that was mentioned as not having paid was not listed the prior month. So hopefully their list is accurate. And even by now, because we're 2 weeks later, maybe even those 4 counties have paid and they're getting ready to release the 15-16 funds. So just waiting on 4 counties, I guess, at this point. That will be resolved and you guys will get your 15-16 distributions before the end of fiscal year 15. And then again, another issue that we've talked about before, that the HIV early intervention set-aside has been eliminated effective the end of September. California no longer qualifies as a designated set-aside state, and so the funding will not be available specifically for those services. DHCS issued an information notice 16-012 providing more detail on that. And you have until the end of September to provide the services and to expend the funding. And I don't believe it's on a cash basis, so you can still be paying for services that were provided in September into October, and so it's not purely on a cash basis. The amount of funding, I guess, is going to be discretionary since California is no longer designated, but you won't be able to spend the funds on HIV early intervention services. And then we actually had a somewhat lengthy discussion on what that really means. And so you still, for these folks, can provide linkage for them to substance use disorder services, but really what you can't do is provide a linkage to HIV services, or which would include HIV pre and post counseling. So you still can provide them linkage to your overall substance use disorder service delivery system, but not specifically HIV counseling and things along those lines. And then we talked about the drug Medi-Cal program, starting off with the quality assurance utilization review claiming. Again, this has been an issue that we've been talking about for a while, at least trying to get counties the ability to get reimbursed for the additional utilization review quality assurance activities that you are now doing for the drug Medi-Cal program. And what we hadn't heard before was that DHCS doesn't have the legislative or regulatory to pay counties for those services. DHCS believes they need either statute or regulation that would allow them to reimburse you for your costs of doing those activities. And that's for the general drug Medi-Cal program. What DHCS did indicate is that they believe that counties that opt into the drug Medi-Cal ODS waiver will be able to obtain reimbursement for URQA services because that functions under the waiver rather than the state plan amendment. So anyway, and it sounds like most folks at this point, I believe, are looking at going under the waiver. The problem is going to be just the timing. And so if you're already doing these things, these activities, it sounds like the soonest you would get reimbursed is once you opt into the waiver. It's also interesting that the state believes that they probably do need the legislation or regulatory authority. And originally they thought they could piggyback off of mental health and the regulatory authority there. But really, from the federal perspective, CMS doesn't really care. So it's interesting that the state is saying that is a hindrance. And I would think if counties really want this resolved and want to get it through, the state could go through either legislation or regulations fairly easily to get you folks the ability to get paid for activities that they're asking you to do. So anyway, that's what's going on with the URQA claiming. Obviously, it's not going to happen this fiscal year. The soonest would be next fiscal year, and it sounds like only for counties that opt into the ODS waiver. There really wasn't anything new on the administrative claiming, which is from Information Notice 14-033. Other than, DHCS is not processing payments on a flow basis. They're doing it every 2 quarters. And so you should have received payments if you submitted claims for the first and second quarter of the current fiscal year. You should have received payment for those, hopefully. And for any claims fourth quarter, those will get paid the beginning of next fiscal year. And then we talked a little bit about the ODS waiver. DHCS had a fiscal webinar on May 3rd. And a whole lot new, other than there was a much larger focus on rate setting, and in fact what Santa Cruz County had done around the rate setting, and different things to look at and to consider as part of setting your rates under, or at least proposing on how you're going to set your rates under the ODS waiver. DHCS reported that they're still in the process of negotiating the Certified Public Expenditure Protocol, as well as the contract terms and conditions with CMS around the ODS waiver. They said the cost report under the waiver will be slightly different, and what I would see there, I think it'll be mainly the difference in certified public expenditures required under the ODS waiver. So it might be slightly different than a county does not opt in to the waiver. They're getting ready with system changes to the claims processing system for the new services. At this point, they've received draft implementation plans from 7 counties. And for those of you who want to see any of those plans, it doesn't have anything on the rate setting. I believe they kept the rate setting out. But if you go and do a search on DHCS on their website for the ODS waiver, you'll get to a point that says implementation plans. You click on that and you'll see the 7 counties if you want to take a look at any of those counties' implementation plans. And then they also indicated that they did post some frequently asked questions, and there are some fiscal things, and that's the link for you there. So any questions on the drug Medi-Cal, or actually on any of the substance use disorder discussion we had? All right, then moving into short title modernization update. This is the project that you all paid for and is being managed by Cal Mesa. And actually there are 3 parts to this, even though I only have 2 of them listed here. The first actually is the MITA, the Medicaid Information Technology Architecture aspect, which really involves looking at how to integrate behavioral health with primary care and into the overall health system. And really they had no update on that portion of the project. The second part are the short dwell 2 system improvements. And they did report out that they had posted survey results to CBHCA's Financial Services Committee website. And this is input that they've received over the last couple of years from you folks. And so you can kind of go through here, and there are 2 top areas they identified: improve reconciliation between the claims and the remittance advice, and then fixing current outstanding bugs in the system. As part of fixing enhancements, they were looking at the 276, 277 transactions, and how to improve that. And I think really for you folks, where the biggest issue is around the 837s and the 835s, and then also allowing you to submit electronically claims that are over a year old and receive a remittance advice. So they're working on those. And then there's this whole thing about short dwell 2 is migrating to this new behavioral health information system that they're saying is going to occur within about a year. And they're trying to do potentially some of these enhancements to the system as I guess, as part of that migration or after that migration. And really, what was interesting, well, it's not interesting. This raises a question. Part of why this whole short dwell modernization project started was because DHCS indicated they could no longer support short dwell 2, and they wanted to look at alternatives. And if they migrate to this new BHIS system, it's questionable, I guess, whether the short dwell modernization project really needs to exist, because if that is going to be the platform and DHCS can support it, then we may not need this project to continue. But Cal Mesa was going to look at that. And so that was on the system side. And then the last part of the short dwell modernization project, and what we probably had the most update on, was the fiscal and delivery system update. And so Harbridge Consulting had been hired by Cal Mesa to conduct the fiscal and delivery system pilot project with a select group of counties. And Harbridge reported out to the governing board in April, and what they were able to tell us at the Financial Services Committee is really there were 3 different conclusions or issues that arose as a result of this looking at the data and analyzing the data with the pilot counties. One is that under the assumptions that we were under when we went into Medi-Cal, especially mental health consolidation, beginning back in 1995, that those assumptions have changed. There's different funding now than we used to receive. There's now, we've got the 2011 realignment. We have MHSA. The state plan amendment's been changed. We operate under the waiver. The diagnostic carve-out that we operate under is different than what was set up back then. And one thing that's really interesting is you look at the number of lives that are covered under the waiver has grown tremendously. We were around 1.5 million beneficiaries when we started this thing back in 1995, and we're up around 8 million or so beneficiaries now. So it's definitely grown, it's changed, and so that was one of their findings. The other thing that they brought up was just the whole fiscal payment structure, and looking at the large cash obligations that are incurred under this existing structure at the local level and waiting to get reimbursed state, and that there should be more efficient ways of reimbursing you for your certified public expenditures if that's the way this system is going to continue. And then the last thing was really looking at the strengths of what the county mental health plans do versus what managed care plans do. And one of the questions that they're asking is, should the risk-bearing plans or the managed care plans take on inpatient services rather than having the county mental health plans do that? And there's really 2 different reasons for that. One is there are some recent federal regulations that give the risk-bearing managed care plans some flexibility around the use of IMDs for inpatient services for short-term stays, as well as the managed care plans deal with inpatient services both for Medicare and on the commercial level. So it's again, is that a strength that should be considered a county, or is it something that maybe the managed care plans might be better off managing than the county mental health plans? So, report out, they indicated CBHDA in working with Cal Mesa, I guess we'll be determining the next steps in terms of where to go with this. Apparently there is a little bit of funding remaining in the project, and so I guess the question is whether there wants to be further discussion around some of these fiscal issues. Do you want more system improvements, to pay for system improvements? So that'll kind of be coming out, I would imagine, in the next couple of months. So that was kind of the report out on the short boil modernization project. Any questions?
Nothing yet.
All right. Moving into claims payment update. Again, all these projects we've been talking about for quite a while. The electronic funds transfer project, San Francisco is in the testing mode, and DHCS is documenting processes for lessons learned when other counties are put on to electronic funds transfer. Apparently there was some sort of transition of servers that occurred, which kind of disrupted things, I guess, a little bit, but that should not happen with other counties once the EFT service is available for other counties. And then we talked briefly again about this adjudication of claims with multiple aid codes. And I think I reported the same thing out last month, that DHCS thought they were going to have the fix by next month. And really that would give you the ability, or would give the system the ability, to adjudicate the claim at the highest paying and approving aid code, so that you could maximize the FFP. At this point, DHCS indicated that's been delayed until September because of this SB 75 project. And DHCS will publish an information notice once they're ready to move a little bit more forward with it, as they're trying to reach resolution. Because again, a lot of these claims go way back. And they also indicated to pay attention to the system change schedule that they put out for the short boil system to see where the status is of that project. So any questions on the claims payment? All right, moving into the MHSA update. So DHCS did receive the CBHDA letter asking for resolution on just how the Information Notice 11-15 is reported, the revenue and expenditure report, and the treatment of innovation reversion. And DHCS indicated that they are putting together a response, which should be available to you folks soon, on how to resolve these issues on the revenue and expenditure report. And they weren't able to tell us any more than just they were formulating a response. They did indicate that they're working on some fiscal regulations for MHSA. And so they've been saying that actually for many years. But the nice thing was that their DHCS wants to put together a work group to incorporate some of the counties, as well as the Oversight and Accountability Commission, to review and provide input into these fiscal regulations. So I believe DHCS was going to reach out to CBHDA and have CBHDA identify the counties that will participate on that work group. And hopefully that they will allow input, and it will be a more of a joint project together, rather than them just telling you this is the way it's going to be. So, but it's good to hear that we are finally going to have some fiscal regulations, and that you will have a framework around which MHSA, from a fiscal perspective, operates. So beyond just the vague and ambiguous act itself. So that will be nice. A couple other things that I didn't put on here. One is, so the OAC had been coming to the meetings, and they had indicated that the May Oversight and Accountability Commission meeting at the end of this month, which is actually I believe next Thursday, that meeting was going to be dealing with reversion. They didn't come to the meeting. They didn't say this, but I looked at the agenda, and there's nothing on the May Commission meeting regarding reversion. So I'm not sure when that will occur, but hopefully they'll come back and invite some counties to participate and inform not only the commission but other stakeholders as to not just why funds, why you have large unspent fund balances, because a lot of folks don't understand the county processes and everything that goes into why you have these large fund balances. At least some of you do. But I will also say that there is within the OAC a financial oversight committee, and they are meeting this Monday, and they have on their agenda a fiscal reversion policy project. So it's definitely something that the OAC is looking at. They're getting pressure to look at, but it doesn't sound like it's going to happen as part of their May commission meeting. So any questions on MHSA? All right, going into the state and federal budget update. You know, as I think I reported out last month, the HCS indicated that they are not going to change the allocation percentages for the current fiscal year, which I think is good news, since you know you're already 3/4 of the way through the year, and in terms of the revenue received from that fund, and so to change them at this point could have been somewhat disruptive. And they did actually make it official through a information notice, so you can take a look at that. But it basically says at the top of the second page, there's no change in the allocation schedule in 15-16. So that gives you the official notice that they aren't changing the allocations. They indicated they are still trying to put together the allocation schedule for 16-17, getting feedback from both CBHDA and CSAC. Their goal is to have this schedule out prior to the first distribution in September. So I would hopefully, you know, sometime in August, you'll see that. The one thing they also mentioned is that they are going to touch a little bit on future growth as part of that information notice, I guess, that will accompany the 16-17 allocation schedule, and will hopefully address you know, this concept of the rolling base that we're used to under the 1991 realignment. We'd like to have it apply to the 2011 realignment just to make it easier to budget. And so we'll see what they say in the information notice, as well as I'm sure CBHDA is involved in discussions around that currently. And then the 14-15 behavioral health sub-account growth, which is I believe it's roughly $60 million that is from the 14-15 year. They have those funds, or they don't have a formal recommendation on how to allocate those funds. So I would not anticipate them to come in during this fiscal year. Hopefully we'll get them, you know, early next fiscal year. I believe the 13-14 allocation out in September of 2015. So which actually is interesting because that was about 3 months later than the prior year. Hopefully that they will have them out by this September, and it doesn't drag on too long into 16-17, because again, you know, these funds from 14-15 that theoretically you could have used to fund services, but the state's just sitting on the money. So any questions on that?
There is a question.
Okay.
What is the probability that behavioral health sub-account base will be met for fiscal year 15-16?
So the state's saying it will be. You know, it's kind of been tracking pretty close. So, and they're actually they being the state is projecting some growth. So I would think it will be met unless we have the same sort of fall off on the sales tax revenues that we just saw with personal income tax in April. But I think, you know, at this point, I wouldn't revise my 15-16 budget below the base because I think it probably will come in. Like I said, it's pretty close right now, but I think it's got a good shot at least hitting the base. But again, we've got several more months before, because again, the fiscal year on this, what is September through August in terms of the distributions. So from a cash basis, so we have a couple more distributions to go to make sure we hit that base. All right, anything else or move on?
No, that's it.
Then we had the work group updates. So, and we talked about this last time because this was really good news that CMS finally did approve the fiscal state plan amendment that incorporates the supplemental payment form or program, which allows you to get reimbursed above SMAs for any of your certified public expenditures from the period of January 1st, 2009 through June 30th, 2012, which I believe is the last year we had SMAs in 11-12. DHCS said they're coming out with the supplemental claim forms and instructions soon. Again, this was another work group that they were hoping CBHA could provide to help provide some input into the forms so that from a county perspective it makes sense, both from a county and a cost report perspective it makes sense in terms of what you're putting together. The initial claim will cover January 1st through the end of 9/10 because they're waiting until the cost reports have been settled before making the supplemental payment. They said don't anticipate any of these payments until fiscal year 16-17, and then they'll release the instructions for both 10-11 and 11-12 once those cost reports are settled. Although it was interesting, in I believe both the January and the May revised budget, they have the entire amount shown in next fiscal year for all the supplemental payment program. So I don't know if that means that they anticipate settling 10-11 and 11-12 next fiscal year, or if they just put it in as a placeholder. So the other thing we did talk a little bit about is that you can submit claims for each legal entity where, like I said, CPE were incurred above the settlement amount. And so if you incurred a CPE in paying a contract provider above the settlement amount, whether it was SMAs or published charge, you may be able to submit a supplemental claim for those legal entities. I think the main impact will obviously be on county-operated legal entities where you incurred cost in the form of, you know, salaries and benefits and services and supplies in excess of the SMAs. And it's probably less likely where you would have potentially paid a contractor above the SMAs. But if you did, you'll be able to potentially get FFP for the costs because those are your certified public expenditures above what the settled amount was for that legal entity. And then it wasn't really a work group update, but we kind of got into this. DHCS indicated that they updated the Medi-Cal Administrative Activities, or MA, implementation plan with CMS, and this was just the mental health portion of the implementation plan, so not impacting the public health side, and really was looking at some changes to definitions and invoicing, looking at developing parallel codes for activities that are not related to mental health, be effective this July 1st. But the good thing is, it should resolve also some of the Medi-Cal percentage calculation issues that many of you have had with the auditors, where they're saying they've got to, or that you've got to apply the percent of your entire county Medi-Cal population, your entire county population that's Medi-Cal. You needed to use that percent. That this will clarify that your percentages will be based on your actual clients served in terms of the percentage of Medi-Cal, which has been an issue with the auditors for quite a few years now. Unfortunately, you will need to submit, it sounds like, a claiming plan, a new MA claiming plan. But where it's going to go is, even though this is effective July 1st, you have until the end of September to make it retroactive to July 1st, similar to state plan amendments and things like that. So you'll have some time to hopefully put it together once all the final pieces and everything's known about what you need to do. And we did request that the MA consultant come present at the next Financial Services Committee meeting, so that everybody can get up to speed on what's going on in terms of these changes to the MA activities. But it does sound like, at least on the percent of Medi-Cal, sounds like a really good resolution in your favor in terms of what CMS approved. So any questions on any of that stuff?
There's a question. Is the supplemental claim for mental health or SUD?
It's purely for mental health and not for SUD. And to be honest, the only reason we were I think able to do it is because it didn't have any impact on state general fund. But in any case, it is purely just for mental health service, Medi-Cal, especially mental health services and certified public expenditures incurred by the Medi-Cal, especially mental health plans, and is not related to drug Medi-Cal.
There's another question. Our MA coordinator said that the MA plan wasn't approved by CMS yet. Is that true, or how might I verify this?
I would, yeah, I mean, I would suggest verifying it with Chuck Anders at DHCS. I mean, let's see. Yeah, he said the implementation plan has been updated with CMS. Well, and so maybe that's part of the thing, is it hasn't been totally finalized yet or hasn't been approved. But again, and maybe that's what Chuck was talking about when he said, even though it's effective July 1st, they have until September 30th to get it approved by CMS. So maybe they're still working on some of that. But again, I would email Chuck Anders at DHCS if you want to find out more, or at this point, because we're only a couple weeks away from the June Financial Services Committee meeting. You may want to wait till then. But clearly, if there hasn't been any guidance provided to counties yet in terms of how you need to update your claiming plan, so there's two things. One, you'll have to update your claiming plan, but then also you'll have to update your your codes within your claims processing system. But if there's no guidance out yet, then it may not be approved yet. But it sounded like from DHCS that it was pretty close, if not already approved. All right. Then we got into the county-to-county issues, and we started off talking about the Continuum of Care reform, or AB 403, and Kirsten from the executive director of CBHCA came in and gave us an update on what's going on with the continuum of care reform. And really, this is the group home and foster care reforms that are, I believe, effective this coming January. And there's a lot of questions, I think it sounded like, that were still out there, such as, is this just expanded services to the same kids, or are these new kids that you need to go out and try to serve? And then really, I think the main thing from a fiscal perspective are whether there are any Prop 30 state general fund obligations as a result of this legislation. I think that is where there's going to be a big difference between the administration and the counties. I guess there are three components to this. One is a child and family team. So every child case would receive a child and family team, and mental health would be a participant in that, which would be, obviously a larger workload and cost to the county mental health plans. There's also the whole therapeutic foster care, and whether that's a new service or an existing service, and CBHDA is going to look at it with their attorney. And so again, from a Prop 30 perspective. And then they're looking at changing the names of group homes to these short-term residential treatment programs. And in doing that would require the Medi-Cal mental health plans to go out and certify every short-term residential treatment program for Medi-Cal, especially mental health services, if they were going to provide Medi-Cal, especially mental health services. This will be discussed. There's a small county retreat next week, and that is one of the topics. And if there's a little paper on the small county handout website under CBHDA that has a kind of rough methodology for looking at some of these costs at the local level. You can see it here. And again, this will be discussed in significantly more detail at the small county retreat next week. And really, I think what the counties brought up is that really want clear definitions in terms of what you're responsible for. It sounded like there was another program where you thought it was your responsibility, and then you submit a Prop 30 claim or try to get some state general fund reimbursement, and the state said it was optional or something like that. So it's really important to have it very clear what are the mandated responsibilities of the counties. And I guess the Department of Social Services at the state level is providing data to you guys on the number of kids. And then I believe we're trying to get more information on the number of locations and where these are, so that each county can kind of figure out what the impact of this CCR is on your individual county. So I would imagine a lot more to come. I will say, and we'll talk about this at the Fiscal Leadership Institute, the state, I believe, put in, I want to say it's under $7 million in state general fund monies for this, which is clearly a huge disconnect from where CBHDA thinks the costs are. So there's a huge divide between the administration and the counties at this point. So then we talked a little bit, if you remember at the prior meeting, DHCS sent a supervisor from Audits and Investigations to talk about the AOD audits, and we provided a little bit of feedback that yes, that was great. It was very helpful. There was a suggestion that this be an ongoing sort of thing where someone come and speak to you folks at least once a year to see if there's any new issues or in terms of what they're finding and things that you should be paying attention to. And then again, it was brought up that it would be nice to have mental health do the same thing that the alcohol and drug folks did. So we had that feedback. And then we talked a little bit about the Financial Services Subcommittee Charter and how it would be, it's basically run by the counties with a co-chair from the CBHDA staff so that you can kind of share the workload. The motion was passed and would have been taken to governing board. I don't know what happened to that. I would imagine they would have passed that. But it's clear, you heard me talk several times around cost reports and various other issues where DHCS is reaching out to the counties for work groups, and so this subcommittee would obviously be valuable to providing input into DHCS through, as part of these different work groups, and that's what I believe the work group would be this Financial Services Subcommittee. Then we talked a little bit about the Hospital 134 file, which is the inpatient paid claims file for all your managed care offsets. And we've been talking about this ever since we shifted from short dole 1 to short dole 2, and that the state no longer provides an easy way to reconcile your managed care offsets against the claims. And so you folks requested that there be a presentation at the next meeting. And I forget if that was from, one county, Butte County, has developed a way to look at the file, the Hospital 134 file. And really it's just a matter of what the record layout is and how many characters are in each field and what does each field mean. And so I'm not sure if it was Butte that was going to present at the next meeting or if it was they were trying to get somebody from the state to provide you a better overview of what is in the Hospital 134 file. This is a file that you don't access through the short Doyle system. You have to go through the regular Medi-Cal system to get at this file. But it would be nice to know at least the record layout, and then hopefully you'd have some data folks who could download it and parse it into something you could read, because apparently counties that have done this find significant errors in it. And then we talked a little bit about the crosswalk to cost report aid codes during audit, in that the auditors don't necessarily use the same crosswalk that is in the Medi-Cal aid code master chart. And so just be aware of that. If you're getting hit on audit for units of service, you may want to request the detail, especially if it looks like one particular program, meaning the BCCTP program or refugee or one of those programs is coming up short or over, while another program, while your regular short dole Medi-Cal is not, then you would want to raise that issue and try to get the more detailed data from the auditors. But apparently they are having some issues with that, and again, whether it's consistent or not, we don't know. It was brought up, we then talked a little bit about the drug Medi-Cal waiver and looking at capitated rates, and really where this is coming from is Partnership Health Plan is looking at being the provider for, or managing the program for some of the counties that are part of the Partnership counties. And they wanted to know if there was a way to analyze that or to take a look at that. And again, so this is something I believe Partnership, there's a couple of things. I think they're going to be both at the Fiscal Leadership Institute next week, as well as the small county strategic planning meeting next week as well. So probably more to come on that. And then we talked real briefly. LA asked, is anybody interested in the Certified Community Behavioral Health Center? And the answer is yes, because there's been quite a few folks that have submitted letters of intent. That process is moving along fairly quickly. And again, this is I believe we're spending the entire afternoon on Monday at the Fiscal Leadership Institute talking about the Certified Community Behavioral Health Centers and what that means and how it impacts and what that looks like. And we also, San Bernardino brought up that on some of the claim forms that it requires not only that the behavioral health director, but also the behavioral health finance person who's signing it must be delegated the authority by the Board of Supervisors. And they were just asking if other counties have dealt with that. And I'm guessing most folks have not looked super closely at those forms to see that that's what it says. So anyway, they're trying to look at that. Then we didn't really talk about it too much, but it was brought up that there is this new Medicare identification numbers for clients. I think we sent this out as well as there's a link or it's posted on CBHCA's website that talks about Medicare is removing Social Security numbers from their the Medicare ID, so they will be issuing new IDs to approximately 60 million Medicare beneficiaries, including the dual eligible. So, you know, definitely something to kind of keep on the radar. Obviously, it will involve some system changes in terms of what information you have for your clients. And then lastly, you know, just again to bring up the Fiscal Leadership Institute, sponsored by CIBHS, is next Monday and Tuesday. The agenda is posted. If you go to cibhs.org, you can take a look at the agenda or the draft agenda. But I can be talking about some of the fiscal policy issues facing behavioral health, both as a result of the May revise and in general. Like I said, and then the first afternoon will be spent talking about the Certified Community Behavioral Health Centers, whole person care, home health agencies, all these different things. There's a lot of different initiatives that are going on in behavioral health right now, and how those potentially can impact counties. I believe the morning of the second day we're focusing on the drug Medi-Cal ODS waiver and just providing an update there. And then lastly, we'll be closing it out with just providing you guys some updated revenue estimates and some policy considerations on different revenue issues from CBHDA. So hopefully a lot of you folks will be attending that next week, because I think again you're probably getting overloaded with a lot of the stuff that's going on, and hopefully this will help you be able to parse out what's really important to you and figuring out where to keep your focus, because again there's a lot going on. So that was pretty much all I had. Any questions on those fiscal issues or anything else that I touched on this afternoon, or anything else fiscal related?
There's just a question about the difference between the Small County Retreat and the Fiscal Leadership Institute, which I can answer. The Fiscal Leadership Institute, as Mike just said, is on next Monday, the 23rd and 24th, and then a Small County Strategic Planning meeting on Wednesday, Thursday, and Friday. We're not supposed to call it a retreat because that sounds too much like a junket, so we call it a strategic planning meeting, which is really what it is.
Yeah, so, because Shoshana, I was going to say that's where the small counties will, you know, we talk about a lot of these different issues, but really it identifies the policy for the coming, or the priorities for the coming fiscal year in what small counties want to focus on, and from a policy perspective, right?
Right, that's right.
Which is a little different. The Fiscal Leadership Institute is report out, and obviously the Fiscal Leadership Institute isn't just dealing with small counties, so it's much broader. But definitely the strategic planning meeting that hopefully your directors are going to is to identify the priorities, since small counties comprise more than half of the overall number of counties in the state, and they're definitely, given a lot of these different initiatives, they're completely different from a small county perspective from a larger county, and it probably will more coordination among counties, banding together, things like that at a small county level versus the larger counties. Anything else?
One more question. I missed the first 10 minutes. Can you give us the update on the SAPT 1516 payments?
Just that, and so all I'm able to do is say what was provided, and hopefully there's a better update now. But as of that meeting 2 weeks ago, there were 4 counties that had not returned their 1314 overpayments, although again it was kind of questionable because one of the counties had not previously been mentioned as being one of those counties that owed money back. But in any case, it sounded like there were 4 counties that owed money back as of 2 weeks ago, and once those 4 counties return their overpayment, then the state would begin processing the 1516 payments. So that was, whether that's occurred by now, I don't know. Hopefully it has, so that you folks can get your 1516 payments.
No more questions.
All right, then that will do it. We're a couple minutes early, but not too early. So again, hope to see you all at the Fiscal Leadership Institute. And, yeah, have a